Welcome to the Victorian and Tasmanian Primary Health Network Alliance Practice Education webinar series. This webinar is on using patient experience for continuous quality improvement. I'm Paresh Dowda. I'm a practicing GP in Canberra. I also work at the New South Wales Agency for Clinical Innovation and New South Wales eHealth as a consultant GP specialist advisor. I have academic affiliations at a couple of universities, and I'm the editor-in-chief of BMJ's Integrated Healthcare Journal. My special interests and expertise are diverse, but the golden thread that unites all of my professional interests is a passion for person-centered care. I was the lead author of the Australian experience-based codesign toolkit, a toolkit to support improving patient and staff experience, which we'll talk about later in this webinar. I'm delighted to be joined by Gary Smith today. Gary, may I invite you to tell us a little bit about yourself?
Thanks, Paresh. My name is Gary Smith, as Paresh has said, and I'm a practicing practice manager of over 36 years at a 12-doctor owned general practice at the foot of the Blue Mountains. I am currently the chair of QIP and a director of AgPal. I'm a co-surveyor in AgPal and academic director for UNE Partnerships. I also sit on international board called ASQA, the Asian Society for Quality of Healthcare. So as you can see from my short bio, I have a real commitment to the quality agenda and also the patient's experience in delivering of primary healthcare, not only in Australia, but around the world as well. Thanks, Paresh.
We acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands. We wish to pay our respects to their elders, past, present and emerging, and acknowledge the important role Aboriginal and Torres Strait Islander people continue to play within our community. This webinar has been developed by Eastern Melbourne PHN on behalf of the Victorian and Tasmanian PHN Alliance, which is a collective platform for the 7 PHNs in Victoria and Tasmania. The webinar was made possible with funding support from the Australian Government Department of Health. The Commonwealth of Australia, Eastern Melbourne PHN, and the participating Victorian and Tasmanian PHNs do not accept any legal responsibility for any injury, loss, or damage suffered as the result of the use, reliance upon, or interpretation of the information contained in this webinar. This webinar is to be used as a guide only, and practitioners should read and refer to the additional accompanying resource and reference. In this webinar, we'd like to focus on 3 aspects. These are to understand the importance and value of patient experience and how that differs from satisfaction. Understand the factors that matter to patients, and finally, a walk through the Australian experience-based co-design toolkit with primary care and general practice examples to support continuous quality improvement. Throughout the webinar, we will be talking about the what, covering concepts, evidence, and knowledge. As we talk about the what, we would really like you to consider the so what. So what does it mean for you, for your practice and your workplace? By the end of this webinar, we would ask you to consider the now what. Having heard from us and considered your context, we hope you'll have 1 or 2 ideas to test out in your own practice. The now what is what will really make the difference to your patients from this webinar, and therefore is a really important component of this webinar. To begin with, let's just pause. Let's ask ourselves, what do we currently do to understand our patients' experience of care? In general practice, we often do patient feedback surveys. We need to as part of one of our accreditation standards. We might also look at complaints we receive from patients or have a suggestions or a comments box in the waiting area. Some practices around the country are using the Happy or Not tool, a digital tool with smileys which can capture elements of patient experience. So a lot of what we're talking about today is not necessarily new. You might already be doing some of it in any case. Gary, I was wondering whether you had any other suggestions on feedback processes for patient experience.
Thanks, Paresh. One of the areas that we look at in our practice is an exit survey of patients. And generally this occurs when we receive an application for transfer of medical records from one practice to another. I don't usually make those calls in the initial stage if we know that the patient is leaving the area. But if they are within the area, I make the phone call to advise the patient that we've received their request for transfer of medical records and they will take place within the week. Then I sort of ask any questions that may assist us in relation to provide a better service or quality improvement service to our patients. Generally, yes, there are comments around parking and can't see my usual doctor, the standard responses. But there are times when I get an insight in relation to what maybe some of the other issues based around their exit, maybe as a result of poor communication with the reception staff or with the doctor accordingly. So just consider an exit survey as another option in understanding the patient's experience at your practice. Thanks, Paresh.
In fact, the health system already reports on patient experience. These are 3 graphs from an AIHW report on patients' perception of how often health professionals listened carefully or spent enough time with them, or where they felt respected. It is segmented by different healthcare professionals, including GPs. How often do you look at data like this that is segmented to your practice level and individual clinician level? There's an international movement in healthcare quality improvement that talks about how we should stop asking patients what's the matter and instead ask what matters to you. If we were to do this, what would our patients say? Although from the UK, this research tells us what matters to patients. Firstly, it tells us that relational aspects of care matter. This includes aspects like dignity, empathy, emotional support, continuity of care, and language that is understood, and it's illustrated in the top half of this diagram. Secondly, it tells us that functional aspects matter too. That is, access to care, waiting times, environmental issues such as noise, outcomes of clinical care, and efficiency of processes. It then tells us to really understand what matters to patients requires a bunch of diverse techniques, such as observation and shadowing and emotional mapping, in addition to perhaps complaints, compliments, surveys, and so on. Patients tell us they like to be informed and given options. They like staff to listen and not to feel rushed. They want to feel they are treated as a person, not a number. They want the opportunity to ask questions. They value other support services and being connected with them. And they want efficient processes of care that provide a sense of continuity. In fact, many of these elements of what matters to patients are written into the Australian Charter of Healthcare Right: access, safety, respect, partnership, information, privacy, and the ability to give feedback. Many of us do surveys, and in surveys, we aggregate the data and show it and interpret that data by doing percentages. However, we need to be mindful that percentages and aggregation of data carries the risk of dehumanizing the patient experience, as illustrated in the quote on this slide. When we're thinking about patient experience or the aesthetics component of care, we need to be able to understand and contextualize that for our patients and our practice. Some theory on patient satisfaction experience comes from a model called the Kano model or Kano analysis. It's been applied to healthcare and says that, broadly speaking, 3 thresholds for patient satisfaction experience exist. Let's start with the third one of these. We have to make sure we get the basics right. If we don't, the customer delight falls off rapidly. The basics might include, for example, getting the right diagnosis or having a procedure conducted safely. Then there are some aspects of care that are directly proportional to the satisfaction and customer delight. In healthcare, examples here might include waiting lists or access times. And then there are the delighters. This is where the experience skyrockets. This may be telehealth or email consultations as an example in healthcare. However, we only get that skyrocketing satisfaction and experience if we've got the basics right in the first place. Sometimes practices make the mistake of going for the delighters without getting the basics right, and in that case, the experience and satisfaction of care declines rather than improves. Now let's pause and just consider what we mean by experience and how it differs from satisfaction. In many surveys and feedback forms, we ask patients to translate their experience using a cognitive process. On this slide, you'll see an example of such a question from the patient feedback survey undertaken for accreditation. The example we've chosen here is the question asking about your experience of the way the clinician communicated with you at your last visit, and involved you in your decision and involved you in decisions. And it asks the patient to grade that on a 5-point rating ranging from poor to excellent. Experience, however, is what occurs when an individual has been engaged in a personal and memorable way. It often relates to the emotional and spiritual aspect. We often think about ourselves in healthcare as a service industry. To really improve experience, we need a paradigm change, and we should think of ourselves as an experience industry. It's so much about how people feel rather than what they think. Just hold on to that thought, and later on we'll look at a different type of survey to capture the feeling rather than the cognitive component. Gary, I know you have had some thoughts here on hotel-style experiences of patient surveys. May I again invite you to share those with us?
Thanks, Paresh. I suppose a lot of the surveys which we utilise in primary healthcare, a lot of them are about what we call the the hotel type experience in patient feedback. We generally ask about car parking, seating, and if you're in a hospital, about the food. But do we ask them about their clinical satisfaction? For instance, did the doctor's diagnosis or treatment meet your expectations? I think the important thing about surveys, it's really about the patient's satisfaction and their journey.
Thank you, Gary. So you may be asking yourself, why bother? This infographic is a summary of the many different studies that tells us that if we bother and work at improving the patient experience and the staff experience, then that in itself translates into an improvement in quality. The Australian Experience-Based Codesign Toolkit is a toolkit developed from similar toolkits in the UK and in New Zealand, and it's adopted some Australian case studies to illustrate how the toolkit may be used. It provides an approach to continuous improvement of patient experience by working and co-designing that with them and with the staff. In the toolkit, there are 5 phases as shown on this diagram. Each of the phases have tools which may be freely downloaded and adapted for your practice and project. Let's look at each one of the phases in turn. The first phase is about setting up for success. The toolkit lists a number of tools and resources that health services may use at the very beginning of a project when considering improving patient experience. Co-designing visions and workshops early on during startup can really be very helpful and engaging. Here's an example from a general practice in the UK who set out to improve patient experience in relation to access. The team had a series of workshops, including one at the very beginning, where they developed a shared understanding of what it was that they were trying to achieve. This was then co-designing their vision. This subsequently led to a whole range of co-design ideas to test out and perhaps implement in the future. So Gary, I believe you wanted to mention something here in relation to open access appointment systems.
Thanks, Paresh. One of the areas of patient access we are challenged with every day is how do our patients gain access to their practice or their doctor of their choice. This open access appointment system is also known as an advanced access and same-day scheduling. It is a method of scheduling in which all patients can receive an appointment slot on the day they call. At our practice, we've used this method now for over 35 years. A large number of practices which I'm aware of have adopted this approach, even only on a selected day of the week, for example, on Saturday mornings where there are no appointments. Patient access is all about a quality improvement process accordingly. Consider doing some research on open access appointment systems.
As we saw earlier in What Matters to Patients, there are so many ways we can approach gathering the experience, the next phase of the toolkit. This is about understanding the relational and functional aspects of care. Remember, the focus is on experience. It's about the relationship, which is captured so aptly by this beautiful quote that tells us that we're designing a relationship, not just a product or service. At a previous practice I worked in as a medical director, we invited design students from the university to undertake observation in the waiting room so we could consider improving experience in the waiting area. We'll come back to the outcome from this later. Now, remember those feedback forms we talked about for gathering the experience, which turns a capture of experience into cognitive task? Compare that question we showed you earlier with this survey. This survey comes from the Productive General Practice, a program I was involved in developing in the United Kingdom. You'll see that in this survey tool, we're looking at the patient journey through a consultation, from meet and greet to describing symptoms and being able to ask questions, the examination, being involved in decisions, and information in the next steps. The fourth column is about being involved in decision making. Notice how in this survey we're capturing their feelings, not what they thought about each one of those components of patient journey through the consultation process. This is an example of an experience-based survey. Once we've gathered the experience, we need to understand it. A number of tools can be useful here, including feedback events and patient journey maps. Let's look at patient journey mapping. This is another tool from the Productive General Practice. On the top, you have the patient journey from making an appointment to checking in, waiting, attending the consultation to leaving and next steps. Along the left-hand side, you have what the patients dislike and like. This practice that this example comes from also took the opportunity to capture the practice team's likes and perceptions. Once we've got this, we can actually map the information gathered from the previous phase onto the matrix. This is an example from a general practice in New Zealand who did just that. They actually created a wall in the staff room with a large display where all the information gathered was displayed to make some meaningful interpretations. Let's look at some of the findings. Let's look at the positive comments. For example, I like the urgent clinic at least. I know I'll be seen. Good information by nurses with self-management plans, easy to understand. Let's look at perhaps some of the dislikes. Cannot get through on the phone. Tried 3 times. No routine appointments. I have to present to an acute clinic. The doctor waffled way too much. Took too long, and I'd forgotten the care plan we discussed last time. Look, I don't mind waiting for doctors for routine appointments for 15 to 20 minutes, but 1 hour is really too long. Different information given by doctors and nurses. For example, the doctor tells me I'll be wrong when the results are in, and the nurse tells me I have to ring in. The cost issues. And finally, they captured their ideas for improvement. Examples here include, why not have phone appointments with the GP? That would really be helpful. Another comment around phone consultations and also email consultations, particularly for perhaps follow-up visits instead of coming back to see the doctor for those things. The desire to want to have a reminder when a repeat prescription is due. Now, that survey I showed you earlier in the gathering phase about being involved in your decisions. This is an example of how such a survey can be interpreted by the frequency of the different emotions. It yields a very different response to surveys where patients are asked to translate their feelings using that cognitive approach to capturing their experience. So once we've understood the experience, we can move on to then improving it. There are again many tools to use in the improvement phase of the toolkit. But what we have to remember is not every change is an improvement, but every improvement is a change. We must therefore be careful to not just implement solutions, but do so in a systematic and structured way so we get the desired impact. The little pictures you see at the bottom of this slide are an example of the outcome from having the university design students sitting on the waiting area I mentioned earlier. From their observations, the idea of a pod designed to be placed in the waiting area and could be used by patients whilst waiting to help capture information about their lifestyle, weight, height, diabetes risk score, and then translate that into an actionable report for them. That whole process of using the pod took about 4 minutes for them to do and helped them to productively occupy the 14 minutes they were spending on average in the waiting room before being called in by a clinician. Now remember, one of the things that matters to patients is being involved in their decisions. Reflect on the way of how you involve patients in that decision-making process. We adapted this tool for our patients from the Mayo Clinic in the US with permission. It's about how we can involve patients with diabetes in decision-making about their next diabetic medication. This tool takes patients through a decision-making process. Instead of telling them what the options are, the advantages and disadvantages of each of the different medications, we ask them, what's the most important thing to them when they're considering the next diabetic medication? These are the options on the top of the columns: daily routine, daily sugar testing, cost, weight change, low blood sugar, the blood sugar reduction, and the side effects. They might say weight change is important to them and they don't really want to be gaining weight. So we would look down the weight change column and look at what options do they have for medications that are not going to result in a gain in weight. This helps them to narrow down to a couple of choices. We then say, what's the next most important thing when choosing your medication? They might say side effects. So we look down that column and run through the side effects for the two medications, then narrow down after that first question and see what their options are. This might just narrow their medications down to the one choice for them. What we've done is taken them through a decision-making process. The final phase of experience-based co-design is monitoring and maintaining the improvement. There are again a few tools here. The most important thing is we continue to measure using the tools we described in the earlier phases, and in the light of the new information we get, repeating the improvement cycle so we are continuously improving. This diagram from the AIHW provides a beautiful summary of what matters to patients through a series of I statements. It's about interactions that mirror functional and relational aspects of care that matter to patients. The EBCD toolkit diagram on the right reminds us that continuous quality improvement of patient experience is a structured and systematic process and provides us with freely available tools to guide our improvement of patient experience. So we have talked quite a lot about the what. We hope, as we've been talking about the what, you've been reflecting on the so what. What does it mean for you, your practice? Now it's time to commit to a couple of actions, the now what. What will you do next? Remember, it can really be quite simple. It could just be reviewing the EBCD toolkit. It could be about picking one or two tools, such as the experience-based survey, and trying them out. Gary, I'm just wondering whether you have any final closing remarks.
Thanks, Presh. The only comment I have is for us to reflect on why we are in general practice or primary healthcare. And I think it's primarily for our patients. We need to think about the patient-centered approach to healthcare because it's their healthcare, we are co-managing with them. And I think we need to listen to their experiences for us to be able to improve on our quality improvement journey.
Thank you, Gary. We'd like to finish by signposting you to three particular resources: the Experience-Based Toolkit and two resources from the New South Wales Agency for Clinical Innovation, one on improving patient experience and consumer engagement, and the other one on consumer enablement. Thank you very much for attending this webinar.